Dirk, what about neoadjuvant therapy? We actually, for the first time, actually heard about a neoadjuvant trial here. This was Christian Blank's study. So is there a place for neoadjuvant therapy in patients with sort of the bulky high-risk stage 3C, and now we call it 3D disease?
Yeah, I think Caroline already described the challenge for the future in the stage 3 and stage 4 disease areas. We have to wait for long times to see really that the treatment we are giving in our clinical trials are effective. So in the past 5 years ago, within 1 year, we had the clinical results on response rate, PFS, on overall survival, and the study was over. Now we are looking and are not satisfied if we see 1 year overall survival rates. And I think the times are also over that we have, after 1 year, 30% difference in 1 year survival rates, as we have seen, for example, for PD-1 antibodies and in comparison to EPI or DTIC. So I think the differences will be smaller, and probably we have to wait for longer times. And I think this opens the space for neoadjuvant treatment, because I think neoadjuvant trials will give us an earlier insight on response rate, sensitivity of the disease, and also possibly on ways to combine or sequence treatment we have available, which might then be tested in larger trials.
Okay, but I was struck by the almost complete assumption that somehow neoadjuvant therapy would be superior to adjuvant therapy. Reinhard, do you buy into this?
Many people argue like this, but I think we have to be very careful. The principle of neoadjuvant therapy was never systematically studied. So we have these nice studies that show us a perfect response rate, but if we look for Caroline's data for doublet trametinib patients with low ADH and limited tumor burden do better. Even lymph node metastases seems to can respond very nicely. So this does not prove anything. If you want to prove the principle, you have to take the same treatment and split it up in 2 parts, neoadjuvant part and then adjuvant part, and compare it directly to the conventional treatment. And I don't see a study around that will ever investigate this at the moment. So the principle of neoadjuvant is not established. On the other hand, certainly it's very attractive. And it gives us early information, and the big advantage is it gives us tissue for extensive translational research, and maybe these translational data help us to decide which combination or which treatment approach is more powerful.
So a good research tool, but maybe not so ready for prime time.
Exactly.
So just to cap it off, Axel, the Christian Blank study, what did you conclude from that?
I may ask a very provocative question. Aren't we doing neoadjuvant approaches every day with our melanoma patients?
Exactly.
Because it could be, you know, the idea to shrink the tumor, to shrink the metastases in order to make them operable one day, and resect something, do radiation on top of it, you know, and just to do everything to achieve, you know, a complete response and no evidence of disease in these patients. But we're not calling it neoadjuvant, because neoadjuvant is something, you know, which you need to plan prospectively.
Absolutely.
And Reinhard is correct. There is very few studies on neoadjuvant treatment. I believe this is always more or less pilot studies in order to achieve data on biomarkers. That's the, you know, my idea behind neoadjuvant trials. The data are good for Nivo plus EPI, but it was presented at a very early time point, so there is no long follow-up. So it's simply immature data.
Okay, and were you surprised at the results of the Blank study? I mean, that many patients couldn't go beyond their first induction cycle?
No, it was not surprising. I mean, I think we are misled by our classification, because we say neoadjuvant in patients with big tumor load, but these patients, we know they are probably already metastatic elsewhere. So in fact, we treat them as if they were local, because in our head they are stage 3C, but in fact, I think it's more a question of duration of treatment in a metastatic disease that is less advanced, in fact. This is, because now I realize that maybe the question is, if we give a neoadjuvant treatment, okay, we shrink the tumor because we have drugs that are effective on that, and then after we give the treatment for some time, depending on the protocols. But finally, we probably treat in this way some patients who are in the early stage of the metastatic disease. So finally, how long do we need to treat these patients?
Okay, so actually that's a good segue. Since we're talking about metastatic disease, it's a good segue to our thoughts on metastatic disease. So Dirk,